All right, so hello everybody. Um, the thing about exams in medical school is that they take different forms, and just at the moment when you feel like you understand the exams, you understand the structure, the examiner comes out with a different structure, and you're like, but I thought I understood everything that has to do with answering essays on the breasts, for example. But we can tweak the question, and it just occurred to me that I don't want you guys to get into the exam and be caught unawares, because you feel like if it's going to be any of these clinical questions, that all you are going to always have is what is the management of this, and already in your mind you just think it's always going to be history. Let's just talk about the history. It's not all about that. It's about how you write out your points, and that depends on the exact way the question is coined. So I'll give you an example. There's a difference in the way you answer a question that says outline the management of a 53-year-old woman with a breast lump. Is different from discuss the management of that same patient. They are different, right? So basically you should know the difference between outline and discuss, and their English terms. If it's an outline question, all you need to do is almost like a summary of each point. So that's why most of your exams, that's what you are going to find, because everybody just wants a summary. But sometimes you may see discuss. Now, if you get a discussion question, chances are that you will be told what to discuss. Except since you're undergraduates, you probably not get a question like discuss the management, because that is going to be very extensive. It means that you will discuss the history. Now, when you are discussing the history, it means that when you are saying for a patient who has a thyroid problem, when you choose one symptom that has to do with maybe toxicity, maybe hyperthyroidism or hypothyroidism, you must list many of those symptoms and tell the examiner how that comes about, and why a combination of tremors, loss of air, diplopia would be pointing to a diagnosis of hyperthyroidism. It's different from if you are just outlining and you just say, well, you are going to ask about features of hyperthyroidism, like you list one or two and go. That is an outline. But if you are supposed to discuss, that means you must explain every statement. So because it's going to be very extensive and it's going to take a while, chances are that you will be told exactly what to discuss. So instead of saying discuss the management of, you may be told discuss the treatment of a 50-year-old woman with a breast lump. So if you are told to discuss the treatment and you go and start talking about the history, already you know that you may not pass that exam, because they have told you specifically that you should discuss the treatment, discuss the complications of thyroidectomy, and you go to the history and you start telling us you are going to find out about whether it's an endemic goiter. You will likely not pass it. So understand the question. This is so important. So if it says outline, outline questions are actually easier because everybody just used to it. If you just write a line, if you write a line and just say, oh, this is what it means, you probably get your scores. But not so with discussion. So the purpose of this video is actually to talk about scenarios where you have the discussion as the tag of the question, because I've told you generally how to answer essay questions, and I don't think there should be any problem, but it occurred to me that I might not have drawn your attention to this. So I'll give you some examples of discussion questions and how it relates to different areas. So let's say, for example, now you have a patient with, they say, discuss the differential diagnosis, investigations, and treatment of a 50-year-old woman with a hard right breast lump. So you give the introduction. The introduction here is that this is pointing to a malignant pathology. So that's just the introduction. Now they've told you discuss. It means whatever you are talking about here, you have to go in depth. So let's say I want to talk about discussion of the investigation of this patient now. I'm not just going to list out, I won't just say ultrasound, mammogram, FNAC, blah, blah. So when I'm saying, the first investigation I want to talk about, so the way I'm going to be writing is that the most important thing to do that I would like to do for this patient is to confirm the diagnosis. And confirmation of diagnosis is via a tissue biopsy. There are different options of tissue biopsies. One of them is fine needle aspiration cytology biopsy. In the fine needle aspiration, that's the way you are going to be explaining it. The fine needle aspiration has the advantage that it's an office procedure. It is not very painful, and the results can be obtained very fast. However, the drawback is that since it's a cytology, we are only examining the cells. We are not able to examine the tissues, and we know that the mark of malignancies is tissue invasion. Therefore, I would prefer to do a true cord biopsy, do an histology, and possibly do an immunohistochemistry for the patient. So you can see that just on the aspect of biopsy, I've explained the options and I've explained why I'm choosing that. That is discussion. So please, if you see discussion in your exam, don't just list true cord biopsy and light has gone off, so I had to adjust. So don't just think it's sufficient to just say I will do this. You will just find out that out of 1 mark you may be getting a quarter of the mark. Note that. So if you want to discuss, for example, you want to discuss the let's say we have talked about biopsy. Now you want to talk about imaging. You may want to say, I would like to do an ultrasound. The purpose of this ultrasound is to guide my biopsy. If you have more information, you may want to tell us the features on the ultrasound that will suggest a malignancy. You can see, so that is a discussion. Discussion means that it is testing the depth of your knowledge. Right. So let me give you another example that still relates to discussion for this patient now. So you say you want to, when you get to the point where you want to discuss the treatment, it means that you are going to be telling us that there are several options of treatment for this patient. The options include surgery, chemotherapy, radiotherapy, targeted therapy, hormonal therapy, and so on. So you will now choose each of those therapies one after the other. So let's say surgery. Surgery is the preferred modality of treatment, especially for patients with like this with early breast cancer. And the idea is that the abnormal tissue is removed immediately. So there are various options. One of the options, and the most common option, is what is called a modified radical mastectomy. In a modified radical mastectomy, the whole breast is removed with the nipple areolar complex up to the pectoralis major muscle, which is preserved along with the pectoralis minor muscle, depending on the particular subtype of modified radical mastectomy that is being done for this patient. You can then go ahead to explain, if you want to go to the, you can talk about why radical mastectomy is not recommended. You can go on to say there's also the option of breast conserving surgery. There's the option of a wide local excision and axillary dissection in this woman because her breast cancer is early. This will be followed by radiotherapy. In radiotherapy, highly active radioactive beams are shown onto the field of the breast. See, that is a discussion. Do you understand it? So if you want to, so let me go to another example now. Let's say you are told to discuss the differential diagnosis, the investigations, the treatments, and of a solitary thyroid nodule and the complications of thyroidectomy. You must know how to go about it. So all you need to do in your introduction is to tell us what a solitary thyroid nodule is. Right? So tell us what a solitary thyroid. Next, you have to tell us your differential diagnosis of a solitary thyroid nodule. After you now tell us the differential diagnosis, you now say something about each differential diagnosis. For example, if one of your differentials is thyroid cancer, it means that you will tell us based on the history you have been given. Let's say you are giving the history of, I don't know, maybe if it's a 25-year-old or a 45-year-old woman, you must let us know whether this age falls into the bracket of those that develop a particular kind of thyroid cancer. For example, differentiated thyroid cancer is common in the young. So if you say, if the patient is 65 and you mention thyroid cancer, you should be saying it is undifferentiated thyroid cancer that is more common in this age group. That is a discussion. Meanwhile, if the patient is 25 or 30 or 40, you say well-differentiated thyroid cancers are more common in this age group. Therefore, I'll be thinking of whether this is a follicular or a papillary thyroid carcinoma. That's the way to discuss. That is a discussion. So the discussion doesn't mean that you are saying too much really, but it means that you are telling the examiner that you have some information. Let me give you another example that still has to do with this scenario I painted. So with the investigations now, you want to discuss investigation of a patient with a solitary thyroid nodule. You want to talk about the thyroid function test. So the thyroid function test generally is made up of a free triiodothyronine, free thyroxine, and a thyroxine stimulating hormone assay. The TSH is actually the most sensitive in evaluating hypo or hyperthyroidism. If the T3 and T4 values are elevated and the TSH levels are decreased, this signifies primary hyperthyroidism. So that is a way of discussing it. It's different from you just write thyroid function test. I'll do T3, T4, TSH, which may be elevated. That's not a discussion. That is, in that case, what you have done is that you have just outlined what you are going to do. You see? So You must be careful of such. Let me give you another example that also relates to the thyroid gland. So let's say you want to talk about a biopsy. You know, I mentioned biopsy with breasts. The difference here will show. Whether you have been paying attention, it will show. And so if you are going to be discussing biopsy, what you are going to say, the preferred method of biopsy for thyroid pathologies is a fine needle aspiration cytology, not a true cut biopsy, because of the vasculature, the vessels around the thyroid gland. The thyroid gland itself is very vascular, and you don't want to be putting a big biopsy gun into the thyroid. The patient will just bleed, you see. But if you say that you want to do a true cut biopsy, I already know that this candidate is a poor candidate. This person has not been paying attention in clinics. So when you now say it's fine needle aspiration cytology, you now say this fine needle aspiration cytology is best done under ultrasound guidance, so as to watch out for the features that may make the thyroid nodule suspicious, and one can then biopsy it directly. So you see, even as a medical student, you may not know the specific features on the ultrasound that will suggest that it's a malignant problem. But the fact that you are describing it and saying it in such a way will help you. Let me give another example of discussion still on that thyroid pathology. If we say discuss the treatment, a patient who has a solitary thyroid node, you want to discuss the treatment, so you must be able to write out the possible things they are going to do. Are you going to do a total thyroidectomy? Are you going to do a subtotal thyroidectomy? And you must tell us the advantages of one over the other. So for example, you are saying, I'm going to counsel this patient extensively on the treatment options. One treatment option is observation. For example, observation, if I have confirmed, if the biopsy has shown that the lesion is benign. However, there is always a chance that with cytology, a lesion that is classified as benign may actually turn out to be malignant. So I may want to counsel the patient to actually have a surgical procedure to remove that portion of the thyroid gland. Right? So that way I already know that this candidate understands what they are talking about. Now, another treatment option is a subtotal thyroidectomy. In this case, if the lesion is localized to one lobe of the thyroid gland, an option is lobectomy plus isthmosectomy. So the advantage of this is that it may reduce the chances of the patient requiring thyroxine replacement therapy, and then there are reduced chances of hypothyroidism and nerve damage. Okay, so that is a discussion. You know, if it wasn't discussion, you would just say total thyroidectomy, subtotal thyroidectomy, treatment options. That's the end. But here you need to explain the things that will make you to do those things. Now, I would also mention again, in relation to this question, discussion of complications of thyroidectomy. You see, if it's an outline, or if it just says, yes, clearly outline the management of this patient, when you get to complications, you just list it. Here, you cannot just list if it is discussed. So you choose every, for example, common intraoperative complication, excessive primary hemorrhage. Excessive primary hemorrhage refers to bleeding beyond what is expected, which happens during the surgical procedure. This may be due to damage of, this may be due to bleeding from major vessels like the superior thyroid artery, which is a direct branch of the external carotid artery. This bleeding can be very profuse. Occasionally, there can be damage to the anterior jugular veins or even to the internal jugular vein. You see, that is a discussion of that excessive primary hemorrhage. So it doesn't have to be too much, but you have to make statements that show that you understand that. So let me give you more discussions on complications. For example, one of the complications is tension hematoma. So you must tell us, tension hematoma occurs when blood collects in the space that is left behind after a thyroidectomy has been done. In this setting, so in this scenario, what happens is that the patient is unable to breathe. So suddenly the patient cannot breathe and the neck is full. Usually because there's a dressing across the neck, you may not recognize it. So we must watch out. That's why after thyroidectomy, the patient should be on continuous monitoring to make sure that if that complication of tension hematoma occurs, the immediate thing to do is to remove the stitch by the bedside and expose the wound so that the tension on the airway can be taken off. You see, that's a discussion of tension hematoma. Let me give you another example. A discussion of recurrent laryngeal nerve injury. So if you say a complication of recurrent laryngeal thyroidectomy is recurrent laryngeal nerve injury. The recurrent laryngeal nerve is closely related to the inferior thyroid artery and it can be damaged while the branches of the inferior thyroid artery are being ligated. Usually, this complication will be evident in the immediate post-operative period because the patient may develop airway obstruction. This, however, depends on whether the damage to these recurrent laryngeal nerves are unilateral or bilateral. For unilateral damage, the patient may just develop noisy breathing and hoarseness. However, if the patient has bilateral damage, the patient is likely going to have airway obstruction within the first few hours following extubation. You see, that's an explanation. So you don't just say recurrent laryngeal nerve injury and go away. If you want to talk about damage to the external branch of the superior laryngeal nerve, you must tell us that this nerve is involved in tensing of the vocal cords, meaning that such patients may not be able to make high-pitched sounds anymore. So for singers or for people that talk for a long while, it can affect them. You can see that is how to discuss it. If you want to discuss hypocalcemia, hypocalcemia happens to be the most common complication of total thyroidectomy. So if it's a discussion question, you must be able to tell us why. Hypocalcemia is not magical. So if in a patient who had a solitary thyroid node has had surgery, complication of thyroidectomy, hypocalcemia, it is as a result of damage to the parathyroid glands during surgery. It could be complete avulsion of the parathyroid gland. It could be damage to the blood supply of the parathyroid glands, and it can just be crush injury to the parathyroid glands, which are in close proximity to the thyroid gland. This shows up in the early post-operative period, usually within the first 24 to 48 hours, as symptoms of hypocalcemia, which include, you should know that, perioral tingling and numbness. You see, and if you also want to say more things, you talk about the TROSU sign, and that is a discussion. So the discussion tests the depth of your knowledge. Once you don't have that knowledge depth, you will be missing marks in your discussion. That is very important. I hope this has helped you. Apply it to anything. For example, if it's biliary pathologies, you can apply the discussion. Discussion just means that you are not staying at the surface. You are telling us a bit more than it would have been if you were just doing an outline question. I know this video will be of a lot of benefits to you. So if you have specific questions about this video, and you have questions, ask immediately. All right, I wish you all the best in your exams.